The client that I'll be discussing for this case study presentation is SH. She is a 42-year-old woman. She was diagnosed with multiple sclerosis, or MS, last year, although she stated that she has had symptoms associated with MS since she was about 16. She is also diagnosed with depression and an anxiety disorder, and was recently hospitalized in the psychiatric department in the hospital due for the reasons associated with depression and anxiety. She's currently unemployed. She reported that this is due to physical and cognitive limitations. She has issues with her balance and her gait, as well as attention and memory. SH was referred to a speech-language pathologist due to difficulties with swallowing. Her chief complaints include that she has difficulty chewing and swallowing solid foods, and reported that she often feels that food gets stuck in her throat. She reported that she chokes on things like stringy meat, ground beef, and sometimes water. She lost approximately 30 pounds this past year. She also complained of xerostomia, or dry mouth, which makes it difficult for her to chew and swallow certain foods. She reported that her memory has declined over the past 6 months, and her husband reported that she often has slurred and quiet speech, and as she gets tired, he oftentimes has difficulty understanding her. After recording her chief complaints, we did an oral mech exam. Her lip function was within normal limits, although she showed reduced lateralization and strength to the right side of her tongue. She also had reduced elevation and retraction of her velum. Her cough and vocal quality and throat clear were all within normal limits, although she showed reduced phonation time at 11 seconds. She reported that she had difficulty chewing due to TMJ issues, and she had a tongue ring in for many years that caused damage to her molars, which often made it difficult to chew as well. Next, we did a clinical swallow eval. During laryngeal palpation, it was perceived that she had a weak hyolaryngeal elevation and excursion across all trialed consistencies, as well as a slower swallow initiation timing across all those consistencies as well. On thin liquids, she showed no overt signs or symptoms of aspiration on either the single sip of water or the consecutive sips of water. She had more trouble swallowing on the pureed consistency, which we used in applesauce. She had a cough after the swallow. It took multiple swallows to clear the bolus. She was complaining of a globus sensation, as well as we tested her vocal quality after, and that was perceived to be wet. And so on the applesauce trials, we tried a couple different compensatory strategies. We had her do a head turn to the right, which did not help at all. But when we had her do a head turn to the left, it was very noticeable that it was helpful. She said it reduced her struggle to swallow, and it only took 1 to 2 swallows to clear that applesauce. And on the mixed texture, she showed no overt signs or symptoms of aspiration. And we did not do any solid consistencies just because of her difficulty, and she had so much trouble with applesauce. So after the assessment, it was determined that SH has mild to moderate solid food dysphagia. She has reduced hyolaryngeal elevation and excursion. When patients have this symptom, it's likely that they are having PES issues, because with that reduction in elevation and excursion, it doesn't allow the PES to open and then allow the food to propel down the esophagus, which is probably the reason why solid foods are so hard for her. It requires multiple swallows to clear anywhere from pureed to solid food consistencies. She complained of multiple coughing and choking episodes within the last year. Her husband reported that she has difficulties with impulse control, and so when she sits down and eats, she just eats and eats and eats and doesn't have any awareness that maybe she should slow down or not, or take smaller bites. And during the clinical swallow eval, it was very noticeable that she had a lot of stress and anxiety while she was eating foods, especially the applesauce. The plan for intervention for SH is going to start by training various swallow exercises and then putting those into a home program. We're going to first start by training a couple different swallowing exercises. We're going to start with the supraglottic swallow that targets overall laryngeal strength, particularly for airway closure. We're also going to train the Mendelsohn maneuver, which targets laryngeal elevation and keeps the PES open for longer. We're also going to train the effort foot swallow that targets higher laryngeal elevation and excursion, as well as improves tongue-based retraction. We're going to train the Masako to target pharyngeal contraction, as well as the Shakir, which helps with PES opening and high laryngeal elevation and excursion. Once we train these, we're going to put her on a home program. This is going to consist of doing each of those exercises, doing those 5 reps for 3 times a day, and then once her strength is improving and she feels comfortable with doing all these exercises, we're going to increase the exercise program intensity over time. We're also going to teach compensatory strategies. During the clinical swallow eval, it showed that turning her head to the left really helped with getting that applesauce down. So we're going to continue to train that, maybe see what else works, maybe a chin tuck, as well as postural adjustments, because she says sometimes she sits in a recliner and drinks water and then she chokes. And so just reminding her to sit up when she's eating or drinking, teaching her how to take smaller bites, knowing when to do that, as well as she had difficulties with impulse control, and so slowing down the rate when she is eating. We recommended bi-weekly sessions for 8 weeks, and maybe continuing that once those 8 weeks are up, just depending on her progress and how things are. And once we feel like we have the swallowing stuff targeted, we want to further assess her cognitive abilities, maybe help her with some strategies throughout the day that will help her, as well as further assess her speech, because her husband reported on some dysarthric symptoms. After the assessment, we decided to make 2 referrals. We decided to refer SH to get an MBS done, as well as a PT eval. We decided to do an MBS because this will just give us a better look at what's happening with the PES, as well as the extent of higher laryngeal elevation and excursion, as well as just get a better look at what's going on in their inner larynx. And we also referred to PT because she had some complaints about balance issues, vertigo. She says when she stands up in the shower, sometimes she falls over. She can't close her eyes when she's standing up, or else she'll fall over. She's having some gait issues, as well as just overall body weakness. And this is the starting reference that I used, because I honestly didn't know that much about MS and dysphagia, and how to treat it, what it looks like, and it's different for each patient, and there's different types of MS. And so some are really aggressive and they're progressive too, and so our job is just to teach them compensatory strategies, give them exercise programs, and help them maintain their function for as long as possible.